So today I'll be talking about this common obstetric emergency, postpartum hemorrhage. So this is a case-based presentation that I made in Thailand on 27th of May 2019. So we'll just go through the case. So and the discussion will evolve with the case. So it's a 29-year-old female, gravida 1, para 1, with 39 weeks gestation. So she presented with abdominal pain lasting for a few hours, which was episodic in nature. And this pain increased in severity. And the uterus examination by the OBG team revealed a 3 centimeter dilatation of the uterus of the cervix. And then she progresses to second stage of labor, and OBG obstetric team starts oxytocin, and they would be mandated to use vacuum to extract the baby. And this baby would be a large baby, 4.2 kgs weight. And after delivery, 5 minutes later, they remove the placenta. And oxytocin, they would continue as a slow infusion. So after 20 minutes of this whole fetus delivery, so she starts having a pervaginal bleed. So at that point of time, the blood pressure is 120 by 80, pulse was 90, so respiratory rate is 18 per minute with normal capillary refilling time. So the question I have for the panelists or for the audience, since it's a case-based discussion, would be what would be the, would you be comfortable with these parameters with an estimated blood loss of 500 to 1000 ml? So she's had a blood loss, TB loss of 500 to 1000 ml with these above vitals. So the question I would have for the audience would be whether these vitals would keep you comfortable. So the answer is no, because this is PPH. This is postpartum hemorrhage, and we need to initiate resuscitation. So what she needed at this point of time, or what the audience would have to reiterate, is that she needs to be put on a monitoring. She needs to be moved to ICU bar high dependency unit, and resuscitation procedures have to be started. So the question again would be what sort of a resuscitative modalities one would use. So the obstetric team concurrently starts prostaglandin, 1 ampule IM every 15 minutes. So the resuscitation one would expect is you would put a 14 gauge cannula and start fluid resuscitation. So although as you see, the point that I am wishing to make is with vitals being normal and with a hemorrhage of 500 to 1000 ml, which qualifies as postpartum hemorrhage, so our resuscitative efforts should be ahead of all these vitals getting into disarray. So that is the key message, because you need to identify when there is a loss of 500 to 1000 ml. I think resuscitative modalities have to be initiated. I think that is the message we need to convey. And as we put the 14 gauge cannula, you need to send off bloods for blood grouping and cross matching, and have to send for complete blood count, coax and fibrinogen, anticipating that she would continue to have blood loss and she would decompensate. So that is our understanding. So obstetric team does the pervaginal examination, and they see this hyperemic uterus, but there are no tears in cervix or vagina, but the uterus is very hyperemic. Now, as you are doing all this, you have started, obstetric team has started prostaglandin, oxytocin was on flow, then you have started resuscitation 14 gauge. She becomes cold and clammy, feeble pulse. Blood pressure is 70 by 40, and she's become very tachycardic at 158. She's become tachypneic at 34 with delayed peripheral capillary filling. So the question I would ask the audience is, what do you think would be the estimated blood loss at this point of time? Because now she's become hypotensive in the face of you resuscitating the patient with tocolytics or with uterine contractile agents along with your fluid resuscitation. So here, once this sets in, your estimated blood loss is more than 1000 ml. So because 500 to 1000 is when vitals appear normal, then they decompensate. So approximately you would have in mind that her blood loss is more than 1000 ml. So I think that is what she manifests with: tachycardia, tachypnea, hypotension, oliguria. So these are all the markers